Hello, Dr. Adriano Maeda. Thank you very much for accepting the invitation to take part in our conference. And we have the opportunity of seeing your presentation, which is about intracranial pressure and brain compliance in pediatric patients. I would like to thank very much the organizers. And I would like to pay my tribute to Professor Mascarenhas and the whole team that is working very hard with research to move forward in terms of discoveries in science and to provide benefits to our patients, in my case, pediatric patients. So let's talk a little bit about this is just a script. Very briefly of everything that we will be talking about. I would like to discuss with you intracranial pressure and compliance. And although this has been widely addressed here by other speakers, then we are going to talk about the importance of brain monitoring in brain compliance in pediatric patients, and then a little bit of the work that we have been doing and we are doing in clinical research with a brain for care sensor. So, and this is a classical slide which shows us the Monroe-Kelly doctrine. So the skull is like a closed box, and the brain is in the skull, just as other types of intracranial parts, which are blood, arterial, and venous structures in CSF. These structures and components, as they are all within a closed box in normal conditions, they have a constant volume and they have a constant ICP, which is normal, and patients can do their activities normally without any type of neurological compromise. Whenever there is any disease that will take to the increase of any of them, for example, if there's an increase of the brain mass, for example, with a brain tumor, or if there is an increase of the blood component with intraparenchymal or intracranial hemorrhage, both the ones from trauma and the spontaneous ones, or if there is an increase in the CSF inside the skull, what happens is that there will be an increase of intracranial pressure because the skull cannot be enlarged along with the other components. So this works, it's like a pressure cooker. So there's a fixed structure and the content within the structure may increase, and this will lead to something that we call intracranial pressure. Usually there is a phase where the system and the organism upsets itself, which is the compensated state of intracranial pressure. There is the mass, there is a volume that is above normal, where liquor and the arterial or venous compartment go out and accommodate. But there will be a time where the increase in volume in the skull cannot be tolerated anymore. It will lead to an increase in intracranial pressure. So there are people that they have a closed skull with an increase of the volume in the skull, and this will lead to neurological injuries that may be severe, which ultimately, if this is not corrected, this may lead to brain lesions that could be very severe and ultimately to a deep coma and death. So intracranial pressure in the neurosurgery and in neurosurgical diseases, this is very significant. We must control it, and we need to treat those patients appropriately. This is an example of a curve showing, which is a chart showing the evolution of intracranial pressure according to volume. So there are studies always related to intracranial pressure monitoring, and usually, and we are going to quote further ahead, this is done most times in the most faithful way, approaching the nervous system. So we need surgeries to put an ICP monitor to measure it appropriately. So the brainful care sensor and the Professor Sérgio's idea is very helpful for us with that regard. So this pressure curve is a curve that we see in adults. So there's an initial phase where ICP is compensated here in blue. So here there may be an increase in volume, but there will not be a major increase in intracranial pressure. So here the patient will not have any symptoms at all or very minor symptoms. After that, we have the compensatory reserve. CSF or venous content is reduced in order to maintain intracranial pressure. However, this has a limit. It has a maximum limit. And after that point of increase of intracranial pressure, we have an increase in the risk of major injuries, major abnormalities in terms of brain perfusion that we call cerebral ischemia or herniations, where brain compartments in the skull will go down and leads to a collapse of mass, and then the pressure of the mass over the brain stem. And if this is not corrected very effectively, this will lead patients to die. However, so the relationship of intracranial pressure is closely related to compliance. So all speakers before have mentioned that. So in the blue phase, the compensation phase, compliance is normal. When we have a compensatory reserve of pressure, compliance goes down. And then in intracranial pressure decompensates, compliance gets worse too. So there's a very clear relationship here between intracranial pressure and compliance, and the brainful care sensor is helping us in this regard so that we can detect these compliance changes so that we know in which point of the curve the person is. As here we are talking about children, there is a certain unique features in pediatric patients. You can see here, especially on the curve to the left, that infants with a closed skull, the curve is steeper, meaning that the compensatory reserve, the period of the compensation of intracranial pressure, is shorter, and we see this clinically. We who look after pediatric patients and children, we can see something. The children is well, and then suddenly they deteriorate very fast. So the use of a device that can detect in which point of compliance someone is can be very beneficial for us to address this person earlier on. So what happens is the person is doing well, feeling good, and then all of a sudden they might have a seizure or have a cardiological compensation, because little children also have um, they have bradycardia or altered consciousness. So children have this unique feature. After 14 years of age, they are more or less more similar to adults, where compensation takes place. And then there is a decompensation that's slightly later in the cases of intracranial pressure. Moreover, why is intracranial pressure important for us to keep homeostasis? For us to keep the appropriate operation of your brain and your body. So here you can see something that we call um, cerebral perfusion pressure. We need to have appropriate pressure so that the blood flow in the brain goes to the nervous system and can perform all the exchanges and perfusion uh, in order to support the normal vascular and physiological um, functioning of the brain. So here for you to keep a cerebral perfusion and pressure, there is a very close relationship between the MAP that we measure with the sphygmomanometer and intracranial pressure. So the relationship between the median arterial pressure and ICP needs to be kept so that the cerebral perfusion pressure is correct. If it's fixed and there's an increase in intracranial pressure, what will happen is that there will be a reduction in the cerebral perfusion pressure. So if the cerebral perfusion pressure is below 50 millimeters of mercury, there is hypoperfusion, cerebral hyperperfusion. There's not enough blood supply to the brain tissue, and this leads to ischemia. On the other hand, on the other end of the curve, where there is brain edema, there is hyperperfusion, and this is also pathological, and this is also a problem, especially in more severe cases. So this is why intracranial pressure is so important for us to be able to treat these people appropriately, and so that we can have a more favorable outcome for the treatment of these neurological diseases. Today, how do we measure intracranial pressure? I, as a neurosurgeon, we use several different devices to measure intracranial pressure, including the gold standard, which are the catheters that we put in the ventricular system, intraventricle sensors that are connected to a monitor and that provide the exact value of intracranial pressure. Moreover, we can have interparenchymatous catheters that are put in the parenchyma, or epidurals above the dura mater, or even in the subarachnoid region. And these devices provide us the level of intracranial pressure in these patients. However, all these devices, they need to be inserted in the nervous system. So I need to take the patient to the OR to open the skull and to install this so that I can measure it more appropriately. This is what we do currently. Now, when we measure intracranial pressure, I'm going to use the curves that have been widely discussed here. So whenever there is a normal intracranial pressure, we have this wave here, where P1 is higher than P2 and P3, showing that this is a brain that has normal compliance and appropriate ICP. However, whenever there is an increase in P2 and it goes above P1, it shows that this patient is in a process of increasing intracranial pressure. So this person is being exposed to a condition that very briefly can cause a deterioration in this patient's neurological status, and many things may happen afterwards. For this reason, when we talk about intracranial pressure, we will necessarily talk about compliance of the CSF. So this is the person's capacity, the capacity of the brain of accommodating the changes in volume. So it is within the phase where you have compliance that is appropriate, it's compensated, and right afterwards it goes to the rising curve where compliance is affected. However, the patient does not yet have symptoms until the ICP gets worse and might lead to acute conditions of deterioration with neurological deterioration.
There are several studies being conducted to compare cerebral compliance, and it's quite common nowadays to think what is the best condition to our patients to properly measure ICP and not to be invasive. I guess this is the main issue here. We have to be smart enough to do it. Once we reach a normal ICP and a normal compliance, above P1, P3, and below we have a altered ICP with a reduced compliance with the P2 above P2 and P3. As it has been said before, no need to go into further details. Now let me draw your attention to the importance to monitor our patients and our children. We know that hypertension, intracranial hypertension, if that is not treated, if you do not treat hypertension, intracranial hypertension, you are going to have a decrease in the blood flow that may take to a cerebral tissue ischemia. In addition to add risks to intracranial pressure that will become unbearable, and the skull pressure will be descendant. It will place pressure in the cerebral trunk, and we know that this is a structure where we have the whole functioning of the body from a maintenance perspective. I mean, to maintain conscious, arterial apparatus, cardiac aspects, and so on. We know for a while that pediatric patients, we will perceive sometimes intracranial hypertension in the pediatric population on a rather late phase. That's why I have to highlight once again all the brilliantism of Professor Mascarenhas to include this pre-action. This is a project that is being developed at a pediatric hospital in the southern region of the country. We just take care of pediatric patients. This is what we do every single day. Here a little bit of our mission and what we do. We have 384 beds. We have a high number of admissions. We also perform surgeries and transplants. we do our best in a very assertive manner to deliver the best care ever to our pediatric patients. And we are extremely happy to say that we established our partnership with Brain for Care in 2020, and we have a very close relationship to Brain for Care, and that is so nice. We have this non-invasive monitoring of cerebral compliance in pediatric patients together with Brain for Care. We have some support in clinical research, and we have been carrying out a number of researches in that field. One of them is institutional research, allowing clinical research protocols aligned to our research and innovation department of our hospital. This is not my own work. Actually, I'm here representing all these players and collaborators. We are a number of researchers, and the research center is fully linked to the innovation office. The goal is to assess the morphology of compliance pulse and ICP. This is a project which has been developed together with the methodology, and it is 2 years old already. And this is an outline of our research. We have a control group where we have 2 normal subjects who were diagnosed as being normal from a neurological standpoint. No neurological complaint or whatsoever, and they were assessed as part of controlled group. The other arm is the so-called active group, patients that were included in the ICP arm with suggestive signs of high ICP, and they were included into this second arm. We compile patients, assess them, and if there is a suspicion of ICP, or if there is any test that they have increased ICP, if they have edema, if they have anything, their optic nerve, eye phones, we investigate, we look for the cause of the ICP, and sensors are placed at the subject. We assess patient in the standing and sitting position. And as long as parents give their authorization, we measure pressure by the hachiometry, by the lumbar pulse. We send the pressure, and then we remove CSF and plot data to get a final figure, final result. We started our survey in 2020, and as of April 2022, we managed to close all the groups. We are increasing the number of patients. We started with a 55 active group, control group, another 55, a total of 110, and we're plotting information and tabulating all the numbers. That is being done by a statistician who was externally hired to avoid any bias in the data manipulation, to really handle properly the numbers and to understand within the pediatric population what are the standards within the normality. In addition, we also wrote a paper from disease to non-invasive intracranial monitoring. And that represents a huge advantage, especially in the pediatric population. Now we are able to offer to the little ones a ICP monitoring control. Well, and that's so great. It's so rewarding, and we are glad to be working together with Brain for Care as part of this project. So this is our first publication, and you are all invited to learn a little bit more about Dr. Mascarenhas' background. Dr. Maeda, thank you for this excellent presentation and results, and how much you are contributing in the health sector. In the pediatric field, I am pretty sure that Professor Mascarenhas would be so glad to hear that you are applying all his knowledge in helping and supporting pediatric patients. We have one brief question. Actually is a piece of curiosity of mine, and also because I would like to understand a bit more, how could that be dealt in the pediatric population? And so the concept of compliance and the relationship between pressure and volume to the adult population, that can be easily understood as there is a reduced number of movements, but children, they haven't got yet the full closure of their skull as adults do. So that compensation or compensatory aspect of the compliance is not fully reached. So what would be the difference? What is the gap there between one group of patients to the other? What is missing yet to better understand one to another factor, and how would that change the pathology definition? I don't know if I made myself clear, Dr. Colombari says. Well, this is a study that is being done with the children older than 2 years of age, and we realize that children older than 2, what's supposed to be normal for children over 2 is not normal for adults. Adults would be 7 to 20 millimeters of mercury, whereas in children that would be considered to around 20 or below that. I don't want to give any spoiler, but in the future, we are going to open a bit more such a study to include the children with open fontanella, children ranging from from newborn to 1 month, to 1 year of age. So what is supposed to be normal for open skull is not quite normal for closed skull. If the fontanella is open, the head keeps growing with cephalic impairment. But we believe that there will be alterations. That is physiological, is structural, but that is a match that will take a few years to go. But we are quite glad and happy to be conducting all these projects at the institution together with Brain for Care. Once again, congratulations for your work, for the results. And we are closing this morning sessions, and we are going to have now the release of Brain Science that will be hosted by Dr. Bremer. I hand over to you, Dr. Bremer. Thank you.